Welcome back, everyone. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're diving into a crucial explainer where we're going to demystify the complex logic behind hospital inpatient billing and coding. If you've ever wondered how hospitals actually get paid for the incredibly complex care they provide, well, you're in exactly the right place. It is definitely not as simple as sending a bill for every bandage and aspirin. It's an entire statistical universe, and today we're going to break it down so it makes perfect sense.
Here's our roadmap for this session. First, decoding the DRG system. Next, the MSDRG architecture explained. Then, present on admission rules, followed by inpatient procedure coding logic, and finally, CDI and the financial stakes. Let's get right into it.
Section 1. Decoding the DRG system.
So, the really crucial point to understand here is that hospitals aren't paid per item or per service. Instead, they're paid a prospective fixed amount based on a single classification group called a DRG. Under the inpatient prospective payment system, Medicare and other payers look at a patient's stay, group it with other stays that have similar clinical characteristics and resource consumption, and then pay a predetermined base rate multiplied by a specific weight. And here's the kicker. This happens before the patient is even discharged. It's all about matching clinical similarity with resource similarity.
This workflow shows you exactly where medical coders step in. The revenue cycle obviously starts at admission and care delivery, but right after a patient's discharge, that's when we enter this critical phase 3. Here, all that clinical documentation is carefully reviewed. Coders assign the crucial ICD-10 diagnosis and procedure codes, which are then fed into a software logic engine called a DRG grouper. That grouper spits out the final IPDRG, which goes straight onto the standard claim form for billing. Simply put, if your coding is off, your payment is off.
Section 2. MSDRG Architecture Explained. The MSDRG system first splits cases into 25 major diagnostic categories. Think systems like circulatory or respiratory. Then, it partitions them based on whether a major operating room procedure was actually performed, giving us a surgical or medical partition. But this tiering system illustrates what really drives the final payment: your secondary diagnoses. If the record captures at least one major complication or comorbidity, an MCC, like acute renal failure, for example, you hit the highest payment tier because of the substantial resources needed for that care. A standard complication or comorbidity, a CC, puts you right in the middle. Without either of those, you're dropping to the lowest tier.
And let me show you exactly why that tiering system is so incredibly vital. Imagine a patient comes in and is treated for simple pneumonia, but they also have COPD, which requires extra monitoring. If a coder captures the pneumonia but misses the documentation for the COPD, which is a CC by the way, the expected reimbursement drops from $8,500 down to $6,200. That is an instant $2,300 revenue loss for the hospital, simply because a coexisting condition wasn't translated into a code. Crazy, right? To get that correct payment tier, you first need the right foundation. And this brings us to a really common point of confusion. The symptom that brings a patient in is often entirely different from the final DRG driving diagnosis. The primary reason for admission might be severe chest pain, but after diagnostic workups and clinical study, the physician determines it's actually an acute inferior wall myocardial infarction. That acute MI is the principal diagnosis. If a coder just uses chest pain, the DRG is completely wrong and the hospital is severely underpaid.
Moving right along to Section 3, Present on Admission Rules.
Coders have to append these specific flags, called present on admission or POA indicators, to every single secondary diagnosis. They have to review the record and ask, did the patient walk in the door with this condition, or did they develop it during their stay? A Y means yes, it was present, and N means no, it wasn't. And as we're about to see, that N flag carries some serious weight.
Under the Deficit Reduction Act, Medicare is closely watching the quality of care. If a major complication, like a new deep vein thrombosis, develops after admission, meaning it gets that N flag, CMS might classify it as a hospital-acquired condition, or HAC. And the rule here is strict. HACs generally cannot be used to increase your DRG payment. So even though the hospital spent massive resources treating that DVT because it happened on their watch, it won't act as an MCC to bump up the payment tier. It effectively penalizes the facility and drops them down to a lower payment weight.
Section 4. Inpatient Procedure Coding Logic.
Diagnoses are only half the story, though. We also have to translate surgical interventions into a highly specific procedural code set. As an inpatient coder, your starting point is usually administrative documents like the inpatient face sheet. It's generated by the admission software and gives you a quick snapshot of the patient. You look here to identify the admitting diagnosis and to see if any principal procedures were noted up front by the registration team. But while helpful, this isn't the whole clinical picture. To truly validate those procedures and pinpoint secondary complications, you've got to dig into the physician's daily progress notes and operative reports. The physician's narrative contains the actual evidence. Did a laparoscopic procedure convert to an open one? Was an extra tissue biopsy taken? You have to ensure that every code you assigned is fully supported by this detailed clinical evidence, not just the face sheet summary.
And when you do find a procedure, coding it is kind of like building a specialized formula. Unlike diagnosis codes, which you can just look up in an index, ICD-10 PCS procedure codes are built character by character from specific tables, based directly on the operative report. Take an open appendectomy, for example. The first character, 0, tells us it's medical/surgical. D is for gastrointestinal, T is the root operation for resection, J specifies the appendix, 0 defines the open approach, and the Z's mean no devices or extra qualifiers were involved. 7 distinct characters, every single time. It's like a giant puzzle.
The third character in that build, the root operation, is arguably the most critical one to get right. It describes the primary objective of the procedure. Notice the difference between excision and resection here. Excision is cutting out a portion of a body part, like a biopsy. Resection is cutting out the entire body part, like removing a whole kidney in a total nephrectomy. Mixing these up completely changes the code, and consequently can drive an entirely incorrect surgical DRG.
Section 5. CDI and financial stakes. In the DRG system, accuracy is quite literally everything. Undercoding, like missing those crucial secondary diagnoses we talked about, leaves earned revenue on the table and makes the hospital look like it's treating simpler cases than it actually is, which harms its case mix index. On the flip side, overcoding, assigning high-weighted DRGs that aren't actually supported by the physician's notes, well, that invites aggressive audits from payers and massive financial penalties. The solution here? Clinical Documentation Improvement, or CDI teams. These specialists proactively query physicians while the patient is still in the hospital to clarify vague notes, ensuring what's coded is an ethical, highly accurate reflection of the care provided. By mastering these IPDRG mechanics, from understanding CC tiers to building precise PCS codes, you hold the power to ensure the clinical reality perfectly matches the financial outcome. Every note, every POA flag, and every root operation matters, leaving us to ask one final, vital question. Is your facility's documentation leaving revenue on the table, or worse, inviting an audit? Does it truly tell the story of your patient's complexity? Well, that wraps up this module. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.